afternoon, and welcome to our multi-modality imaging conference series. I'm Miguel Quiñones from the Department of Cardiology and Imaging Center, and I'm joined today by Dr. D.Shah, the director of the Cardiovascular Imaging Center here at Houston Methodist. And today we're going to talk about evaluation of cardiomyopathies. So the outline of the talk is going to be pretty simple. We're going to talk a little bit about ways to classify cardiomyopathies, and then discuss the role of echocardiography and, of course, the role of cardiac MRI, which has provided an amazing improvement in the way we can assess patients with cardiomyopathy. So I took this slide yesterday from our EPIC EMR program. This is one page out of several pages of ICD-10 codes for cardiomyopathy. Good news is that you don't have to memorize this. But obviously, the payers have done detailed classifications of cardiomyopathies, which none of us really use other than for billing purposes. So we can think of different ways to classify cardiomyopathies. This is one that I like, but it's not the only one. I like to think in terms of structural issues, functional issues, and genetic diseases. So in the structural category, you have things such as scar, fibrosis, inflammation, infiltration. In the functional, you have, of course, ischemia being a very important one, toxic agents, pressure overload, chronic pressure overload, chronic volume overloads, as we see in different valvular heart diseases. And then for genetics, there's a whole host of different genetic disorders that themselves can affect the function of the heart as well as the structure of the heart. Now, if we want to be more specific, then under structural, we obviously think of myocardial infarction and scarring from that, myocarditis, vasculitis, such as lupus, sarcoid disease, hemochromatosis, amyloid, left-sided endomyocardial fibroblastosis, and others that are not even listed. On the functional side, ischemia, again, very important, cardiotoxic effects of, for example, chemotherapy agents. Sepsis has been known to acutely influence heart function, even uremia. Endocrine disorders, hypothyroidism, diabetes, there is a diabetic cardiomyopathy, high cardiac output states. On the genetic side, there's a whole multitude of genetic disorders. Here showing some of the most common ones: ARVD, hypertrophic cardiomyopathy, noncompaction, familial dilated cardiomyopathy, Fabry's disease, Duchenne's muscular dystrophy, myotonic dystrophy, and so on. So that's one way of thinking about it. The other way is the phenotypic expression. How does the heart look? This one is a little bit easier because there's not that many ways the heart can look with a cardiomyopathy. It can get big, become dilated, so we talk of dilated cardiomyopathies. It can become thickened, so we talk about hypertrophic cardiomyopathies. And then it can be infiltrated by different diseases, so we talk about infiltrative or restrictive cardiomyopathy. And then there's a few others, for example, such as Takotsubo, that we'll be discussing. So in a way, this is a little bit of a simpler classification because it's more based on appearance when we do imaging. The other ones are a little bit more pathophysiologic. So when we look at dilated cardiomyopathy, the first take-home message is they all look alike. A big heart that doesn't contract well. Now, the etiologies themselves, as you see on this slide, can be a multitude, from ischemic to idiopathic, alcoholic, familial, postpartum, the effects of myocarditis, acutely or chronically, and then even some of the toxic effects of infections and so on. But at the end of the day, most of the time, what you see is a big heart that has a poor contraction and a low ejection fraction. The LV, of course, is universally affected. The RV may or may not be, depending on severity of illness and hemodynamic abnormalities. And the same thing for the atria. They can be enlarged or normal based on disease expression as well as hemodynamic changes. So echocardiography, of course, has been incredibly helpful over the last 50 years in making us pointing the direction towards a diagnosis by showing the heart. So it helps us see that we have a dilated heart or hypertrophic, or there's some findings between the 2D and the Doppler that suggest restrictive hemodynamics. It might point us towards a possibility of an etiology. However, echo does not do that good of a job with etiology, as we're going to see in a minute, but it can point us toward thinking of some of the possible causes of cardiomyopathy. Most importantly, with echo, we assess severity of the impact of disease in terms of degree of dilation of the chambers, LV mass, ejection fraction, and the hemodynamics, diastology, pulmonary pressures, all of which have been discussed recently in previous talks. And there are echocardiographic parameters that we can measure that give us an estimate of prognosis. For example, how bad the EF is, how bad are the hemodynamics. Now we have things such as strain that is coming along with very low values of strain predicting worse prognosis and so on. So the echo can play an important role in giving us an idea of how serious the condition is and potential prognostic indicators. So here we have a dilated cardiomyopathy. The slide says postpartum cardiomyopathy because I'm telling you. But of course, all you see is a big heart that doesn't contract well. Happens to be a young woman in the peripartum phase of having had a baby, and everything fits the diagnosis of postpartum cardiomyopathy, a condition that is very interesting because if you treat the patients and they survive the acute phase, there's almost a 50% probability that in 6 months to a year, they may have a recovery. So it's an important diagnosis to make and to treat because the prognosis may actually be fairly decent for many patients. Here we have another big heart that doesn't contract well. In this case, the RV is also affected. As you can see, the RV function is not the best either. And the two atria are dilated. There is some functional mitral regurgitation. So it's a 45-year-old man. So do we know the etiology? Well, only because of the history. Happens to be somebody that has AIDS. So this is an HIV cardiomyopathy. And patient had been diagnosed 5 years earlier. He was receiving intensive anti-HIV medication. So this is an interesting disease. We're seeing less of it because with the antiretroviral therapy, the actual HIV infection of the heart has come down a lot. However, the mortality is still very high when we see a patient with this condition. And the possible etiologic mechanisms right now, other than HIV infection per se, which is less these days, we still have to deal with opportunistic infections, nutritional deficiencies, but importantly, toxicity from the antiretroviral therapy and cardiac autoimmunity. Those last two are becoming a little bit more common nowadays that we're keeping patients more free from the severe expression of HIV. Now, this one is an etiologic condition where the echo can give us clues for etiology. You see that the heart is a little big. It's not really very dilated. But the important thing is the function is depressed, but you have all these trabeculations in the heart. The short axis shows it very nicely. And this is, of course, a condition called LV noncompaction, which is a genetic disease. And it's thought being sort of a spongy transformation of the myocardium, which is kind of similar to how the myocardium looks in a fetus in the early phases of development. You have these coarse trabeculations and deep recesses covering the endocardium. And basically, there's been several recommendations for making a diagnosis. This is one that has been more popular. You can see these recesses here, and you can see the area without it. So this diagram here shows that if you have these big recesses divided by this distance here, and you have more than two, that is a suggestion that you have noncompaction. When it's a classic example as this one, there is not much of a concern. And this is an area where also contrast echo can help you sometimes, as well as good short axis views towards the apex of the heart. A couple of clues for the sonographers watching the conference. Well, hypertrophic cardiomyopathies, we've even given lectures on that topic itself. It's a condition that actually is quite common. It's a genetic condition. This is the typical example that we all know about. asymmetric septal hypertrophy, systolic anterior motion of the mitral valve producing dynamic left ventricular obstruction. Now, the obstruction may not be present at rest, and it may occur with provocation, as in this case, where with upright exercise, the patient had it, but also Valsalva can show it sometimes very nicely. So these patients, when they get worked up, they always get a Valsalva maneuver during the resting echo, and then depending on the workup, we often also do some exercise maneuvers to see they have inducible dynamic LV outflow obstruction. The important take-home message here is that there is no relation between the severity of the obstruction and the severity of the LVH. Zero. No relation whatsoever. And in fact, the degree of SAM and dynamic obstruction is more related to certain changes in the anterior mitral valve apparatus, where often these patients have anterior displacement of the pap muscles, mitral leaflet elongation relative to the LV size, reduced posterior leaflet mobility, a concave shape of the septum, a hyperdynamic LV contraction, so that as the flow of blood going through with these changes in the mitral valve, it promotes the occurrence of SAM. And that's why maneuvers that make the heart smaller, such as Valsalva, or bigger, such as squatting, will either increase the gradient or reduce the gradient, which of course we use that at the bedside, looking at changes in the systolic murmur with those maneuvers. Now, common things to think about when you see a heart that is hypertrophic is, of course, secondary hypertrophy. Most secondary hypertrophies in hypertension and aortic stenosis tend to be concentric, but occasionally you see a situation where the septum looks a little bit thicker than the posterior wall. The athlete heart is always mentioned as a possible differential. Nowadays, I think we have relatively good techniques to differentiate, because if you have a perfectly normal athlete heart, that heart is going to have normal strain, normal diastolic function. Whereas a patient with hypertrophic cardiomyopathy almost universally have diastolic dysfunction, and nowadays with strain, we also pick up reductions in longitudinal strain. So I think, most of the time we can make that differentiation. Cardiac amyloidosis is interesting because, of course, phenotypically it can look like a thick heart, like in a HCM. Clues there, of course, are many others. We're going to talk about that in a minute. And then typical, one thing that is common is the so-called sigmoid septum in the elderly, which is just usually people past the age of 60, 65, 70, and they have this sigmoid shape in the septum and other abnormalities. We don't call those patients as having hypertrophic cardiomyopathy. Now, in terms of phenotypic expressions, asymmetric septal hypertrophy is the most common, 90%. Concentric, it's uncommon, but it's there, we can see it. And then one that we see still, even though it says 3% on the slide, we still see it quite often, is apical hypertrophy. The last two are very, very rare. So here we have a typical HOCM, but here we have the apical variant. And you can see that a lot of the hypertrophy is expressed towards the apical segments of the LV rather than at the base of the LV. And you have this basically cavity obliteration towards the apex, and often you have this trapping of blood in the cavity of the apex, and this is a typical LV angiogram that has this ace of spade sort of shape that has been used when describing the condition. These people can be suspected from an EKG because they have these typical deep T-wave inversions on the ECG. And one thing to remember, again, for sonographers in the audience, is that if you see something that looks like maybe a hyperdynamic heart, but you don't see well the apical segments, there's attenuation, think of apical hypertrophic cardiomyopathy. What happens is that all these muscles here produce attenuation of sound, and you don't see it that well. However, a couple of maneuvers that you should think of doing. One is color, because color itself can help you see that obstruction and that trapping of blood in the apex. Another one, very simple, it's just a short axis view at the apex. You can beautifully see here how there is just basically almost no cavity, particularly in systole, and a lot of muscle here, and of course contrast. When contrast is given, frequently the pictures are very, very typical, very diagnostic, and rarely would you ever miss making this diagnosis if contrast is given. This is a beautiful example. You can see the apical obstruction here, and you can also see that the very tip of the apex is akinetic, and there is trapping of blood here, and we will hear eventually from Dr. Shah how MRI helps here by showing scarring and so on. So if contrast is used, we should never miss this diagnosis in the echo lab. Now, when we talk about differential diagnosis, then there's a few other rare conditions that we always have to keep in mind. And these tend to be more genetic conditions: Fabry's disease, glycogen storage disorders, mitochondrial myopathies, Friedreich's ataxia, and then occasionally infiltrative tumors can kind of look like hypertrophy, but it's basically infiltration from the tumor. And very rarely a thrombus can pseudo look like hypertrophy. I think this is probably easier to recognize. Of all of these, I'm only going to bring Fabry's disease because it's one condition that clearly looks like it. In fact, this 2D here is taken from a patient with Fabry's. And you can see that phenotypically that could pass for a hypertrophic cardiomyopathy. Very thickened septum, asymmetric, hyperdynamic heart, maybe even a little systolic anterior movement of the chordae. So this could go through a lab and be diagnosed as HCM, and in fact, it's a patient with proven Fabry's disease. It's most prevalent lysosomal storage disorder. It's an X-linked inborn error of the glycosphingolipid metabolic pathway. There is an accumulation of GB3, and that is toxic. It's cytotoxic, it's pro-inflammatory, and it can affect the skin, kidneys, heart, eyes, blood vessels, and heart. And therefore, it can have systemic manifestations. In the heart, of course, it affects the heart muscle, so you get this cardiomyopathy with hypertrophy. Also affects the conduction system with heart blocks, and there's a 20% incidence of cardiac death. Why is worth thinking of this disease? Because nowadays there is treatment. So using enzyme replacement therapy and enzyme enhancement therapy, this condition can be controlled and treated. So that's why it's always good to think about it. Also remember, because it's a systemic illness, frequently you have skin manifestations that you can pick up in these patients. And of course, there might be a family history that you might think about. So this is a condition worth thinking through it, because nowadays there are some therapies for it. Then we get down to the infiltrative or restrictive disorders, most commonly amyloid, sarcoids, hemochromatosis, but then you have more rare ones like the endomyocardial fibroblastosis and some of the infiltrative tumors that sometimes can sneak into the myocardium and produce a restrictive type of physiology. Common features when you do an echo in these patients: rarely is ever will there be LV dilation. So the first thing is that you see a normal cavity size with a varying degree of increased wall thickness, depending on the condition we're talking about. They might even have normal wall thickness, but for example, in amyloidosis, you're going to have increased wall thickness. Diastolic dysfunction is practically universally present, but systolic dysfunction varies. Now with strain, we're picking up a lot more subtle systolic dysfunction, but just a drop in EF depends on the condition and is variable. So and then of course, if you do diastology, often you may find that these patients are already in a restrictive phase of the diastolic dysfunction, but not always. They could be on the early phase of impaired relaxation with normal feeding pressures. So you really have to sort of be suspicious for them and think through it, because otherwise, patient may go through the echo lab and be missed. So this is an amyloid case, pretty typical. Lots of increased wall thickness, even has this little bit of increased refractance of the myocardium, very non-specific. Don't ever put your eggs in that basket, because you could be wrong half of the time. There is frequent biatrial enlargement. EF is all over the place. It could be normal, it could be depressed. But diastolic dysfunction is universal. That one you will always have. And nowadays, with strain, you should have some reduction in strain. So this particular patient has already a restrictive type of high E, low A, but with very low values of E primes, as you can see here. But you may have variation in the degree of diastolic dysfunction. This is a patient that is basically terminal. This is a terminal phase of amyloidosis where basically the heart barely moves. But notice it's still not dilated. So you don't get dilation when you get infiltration with amyloid. But this patient did not last much longer after this echo was done. Again, notice the very low velocities, integral velocities, indicating extremely poor cardiac output. Now, one feature, and this is worth knowing because sometimes you don't have strain, these patients typically have much better wall motion at the apex than at the base. And you can see it very nicely in this 2D echo alone. And that's why when strain is done, you often see this pattern where you have preserved values of strain in the apical segments and very low values at the base. And this has been called apical sparing. It's not 100% predictive for amyloid. And it's not even 100% sensitive. I mean, there's, like everything in life is imperfect, but you see this pattern, you should raise the suspicion that cardiac amyloidosis may be present. And if you're astute looking at a 2D echo, even without strain, you can see that. You can see that the apex contracts a little bit more vigorous than the base. So what do we have here? We have another heart that is not dilated. EF is relatively okay, not hyperdynamic, but it's probably in the mid-50s. There's some atrial dilation. So, without a history, it would be hard to know exactly what this is. However, as you can see on the next slide, there's a very long PR interval, and there's an elevation of PA pressures. Okay, and then we're told that this patient had a non-systemic sarcoidosis. So this is a patient with sarcoid, and this shows some of the features that have been described. In fact, the Japanese Ministry of Health and Welfare published back in 2006 this criteria. Of course, histologic diagnosis is the perfect diagnosis, but not always possible. The clinical diagnosis is easier when the patient is known to have sarcoid. So if you have this patient that is known to have sarcoid and they have EKG changes, variety of different changes, from right bundles to left axis to AV blocks to PVCs or episodes of VTAC, pseudo-infarcts, abnormal Q waves, STT changes. So you have these changes in the EKG, and then you, together with that, you have some imaging changes of either wall motion abnormalities, abnormal LV function, abnormal perfusion, or large patterns of scarring in the CMR that we'll hear about later. If you have an EKG findings on one of these three in a patient that has known sarcoid, you can safely say this patient most likely have cardiac involvement by sarcoidosis. We're going to hear more from Dr. Shah, but this is one area where, again, CMR can be extremely helpful. Strain is a new kid in the block, and again, publications are coming out showing that many of these patients will also have areas of reduced strain. But stay tuned, this is still work in progress. Now, this is about as bad a heart as you can find, right? Both ventricles are horrible. The right ventricle, I think, is even bigger than the left ventricle. The atria are enormous. Cardiac function is terrible. This patient obviously is in trouble, very severe trouble. But what's the cause of all this? Now, look at the right side. These tricuspid leaflets they're like 1 mile apart from each other. The TR is so bad that we don't even see it by color, but it's wide open. So what is this? Well, it becomes very obvious when you do a measurement of serum ferritin, and you have sky-high values. So this is a patient with hemochromatosis. Again, we'll hear from Dr. Shah how CMR can help us in this situation. But I think it's a simple enough test that whenever we have a patient with heart failure in the office and imaging that shows abnormalities of the left ventricle, it doesn't hurt to throw in a serum ferritin. It's an easy test as a screener because these people will obviously always have very elevated ferritin. Now, this is now getting into the area of zebras, things that are a lot more rare. Is this an apical hypertrophic cardiomyopathy? Well, obviously there is something here. But notice that what we see towards the apex has a little different texture to the rest of the heart. And this patient has a very high eosinophilic count. Of course, practically everybody that presents with heart failure gets a CBC. So, this is one thing that, as cute as the 2D echo findings are, if you see what looks like something infiltrating the apex of the left ventricle and sometimes the right ventricle too, in a patient that presents with heart failure symptoms and they have a very high eosinophilia, think of Leffler's endomyocardial fibroblastosis. And this is a slide that courtesy of Dr. Susan Wieger, beautiful slide showing again the infiltration by this particular material full of eosinophils in the towards the apex. There are two variants, the infectious variants, which is basically produced by schistosomiasis, and then the non-tropical or Beckett's. And these abnormal cells are obviously very toxic to the endocardium. Finally, a few of the other two that are commonly seen. Takotsubo, I think, is quite known by everybody now. Is the one of the non-coronary ischemic causes of myocardial infarction. Patients frequently present following a very stressful type of situation, and they come in with an acute MI. I mean, the ST elevation, the echo looks like an acute MI. The most common pattern, typical Takotsubo, is apical, so they look like an LAD infarct. And most of them, not 100%, but certainly in the 80% plus, have a nice recovery over 10 days or so, as this patient did. Now, you may have non-apical involvement. This is one that has that middle segment. This would be looking more like a diagonal type of infarct because the base is contracting great and the apex fine, so one would think of a diagonal or an obtuse marginal causing this, but it's not. Coronaries were clean. So this is a little more atypical variant of Takotsubo. Again, this patient had a nice recovery a week or two later. It's considered a stress-induced catecholamine released with toxicity. So it's kind of like adrenaline toxicity. And there is a animal model. So it has been duplicated in animals that have been exposed to severe stress. And these same animals, if pre-treated with beta blockers and then submitted to the stress, don't get the syndrome. So I think currently there is still, the concept is that these patients under a very stressful situation has almost like a rapid bolus injection of endogenous adrenaline, and there is a toxic effect in the myocardium. And that's one of the reasons why probably it has a reasonable course in terms of recovery, although not everybody. Some people can remain with lingering problems, and there's been some release of cases showing that occasionally there may even be a recurrence in the same patient of the Takotsubo. Finally, one condition that can be a little bit more difficult to diagnose, a lot of suspicion is needed, is arrhythmogenic RV dysplasia. And basically, it's a condition that affects mostly the right ventricle, although now there are cases suggesting that the left ventricle may be affected. It's also a genetic condition. And basically, it usually becomes apparent somewhere between second and fourth decade of life. The the most common clinical presentation is arrhythmia. So these people present with PVCs, VTAC, sudden cardiac death, all kinds of different arrhythmias. There are EKG clues. So you frequently have an incomplete right bundle and or T-wave inversion in the right precordial leads and or the epsilon wave. So the epsilon wave, I'm showing you a few examples. And it's this little blip right after the QRS. This is one example here. This is another one right there. You see right here, right there. These are 3 examples. This one has a little prolonged PR interval. So patient comes to your office, they have palpitations, they have some PVCs. Take a closer look at the EKG because that could be the first clue towards the diagnosis. Now, when you do an echocardiogram, which is usually the first test we do, you're looking for signs of RV trouble. So the RV might be dilated, or you might see some reduction in RVEF, or you might see some regional wall motion abnormalities in the RV. And then you have a good other cause for this. So you have a patient that may have some palpitations, maybe some PVCs, some non-sustained VTAC. Then you do the echo, they have an enlarged RV or they have a little bit of RV dysfunction. They don't have an ASD, they don't have any of the other known causes. The PA pressures are normal. If you're lucky, you get a TR jet. They have no PA hypertension. So you're left with this sort of, I cannot explain why the RV is not good and the patient has palpitations. If you get the epsilon wave, then you are much closer to making a diagnosis. But we all have to have a certain degree of suspicion. Again, CMR can be very, very helpful, and we'll hear more about it later. So I finished with this slide, which is a slide that I think I got from Dr. Shah one time, which is how some of these diseases like sarcoid, amyloid, hemochromatosis can have even a worse prognosis than dilated cardiomyopathies, because we have learned so much about how to treat dilated cardiomyopathies that we can keep these patients alive now with good heart failure treatment. But these other conditions can have dismal outcomes. And the only way to prevent this dismal outcome is to catch them very early, because nowadays there are therapies for amyloid, there are therapies, of course, for sarcoid, and of course there are therapies for hemochromatosis. So the trick with this condition is really try to catch them very early in their phase, because once you catch them in their advanced phase, it can be very difficult to reverse the course. So with this, I'd like to pass it over to my partner in crime, Dipan, who is in his office, and he's going to take it up from here and talk to us about CMR. I cannot hear you. Yeah, there we go.
Okay, can you hear me now?
Yes,
okay,
we can.
So let me just share my slides, and then we'll get started. There we go. Okay, so what I'm going to do today for the next half hour or so is talk about the role of CMR in various cardiomyopathies, and then we'll pick up next week as well with a continuation of the role of CMR, and then also incorporate the role of nuclear and PET. So I think, as Dr. Q showed in that previous slide, we've really got a variety of different conditions that all kind of get lumped into this non-ischemic cardiomyopathy bucket. But they're very different underlying pathophysiologies. And the goal for imaging is really to try to further characterize these different forms of cardiomyopathy. So what I've done here for my talks for this week and next week is kind of broken them down into the genetic, the dilated, the inflammatory, and the infiltrative or restrictive. And I'm going to touch on the first two groups today. And by genetic, we're talking about the hypertrophic cardiomyopathy, the ARVC, the left LV noncompaction, muscular dystrophy. And then the dilated cardiomyopathy, obviously the most common is just our idiopathic dilated non-ischemic cardiomyopathy, but also we'll touch on viral and Takotsubo's as well. And then the last two we'll talk about next week. So let's get right to it. So I think the first question is, okay, I think Dr. Q did a very nice job of showing the power of echo for the initial evaluation of these patients for, when it comes to chamber sizes, LV function, as well as PA pressures. So what are the tools that CMR can add that really can be incremental? I think, obviously CMR can be very good for assessment of LV and RV volumes and ejection fraction, which again, in these patients is going to be key to differentiate, is this reduced EF or is this normal EF cardiomyopathy? But I think more important than that really is this technique right here, the late gadolinium enhancement technique, which now has been out for about 20 years. And really with this technique, we're able to directly image myocardial fibrosis and myocardial damage, as is shown here in this example patient where there's a mid-wall area of hyperenhancement in the interventricular septum. And I think this ability to directly visualize with high spatial resolution the extent and pattern of the damage allows us to classify different types of myocardial damage. First example here is this mid-wall. This in the middle here is a patient who has more of an epicardial pattern of hyperenhancement. And then the third is a patient who has a subendocardial but a global pattern, which again wouldn't fit with any coronary artery distribution. So on a CMR, whenever we see any of these patterns of hyperenhancement, that's a clue to us that this is a non-ischemic pattern of myocardial damage. In addition to that, more recently, in the last 10 years or so, we've also had these newer T1 mapping techniques, which can allow us to get native T1 time, as well as get something called extracellular volume fraction, which is really a measure of the amount of the extent of the extracellular compartment within the myocardium. And I think this last one is an application that I think is growing and emerging, and I think we'll see more and more of this as it helps us to further characterize these patients. So let's start off with some examples of the genetic cardiomyopathy. So here's a first case, and if I just show you the CT images alone, just looking at morphology, I think we can very nicely identify that there's increased wall thickness here all along the apical segments. And right off the bat, we would say this looks like a classic apical hypertrophic cardiomyopathy pathology. When we do our delayed enhancement MRI, in fact, we also notice that because of that apical trapping, there's increased pressure in the very true apex, leading to apical infarction and scar, as we're able to detect here. In addition to that, we've got patients here who has a more garden variety form of hypertrophic cardiomyopathy where there's septal increase in wall thickness. And in these patients, we also oftentimes notice a unusual pattern of enhancement where there's hyperenhancement within the septum at the RV insertion sites, but notice it can be present anywhere within the myocardium. The extent of this has actually been shown to be associated with arrhythmogenic as well as cardiovascular outcomes. This was a nice multi-center study from about 5 years ago, which looked at a series of almost 1,500 patients with a diagnosis of hypertrophic cardiomyopathy and identified that those with a large scar burden, and in this case, it seemed that about 15% or more scar burden was the threshold that was associated with a worse risk. These patients had a higher risk of sudden cardiac death. And they also found that in addition to sudden death, these patients who had a larger scar burden also had an increased risk in end-stage heart failure death as well. So that total mortality was driven both by sudden death as well as heart failure death. And again, there's a progressive relationship with increasing scar associated with worse outcome. Now, in these patients with hypertrophic cardiomyopathy, I think it's also important to recognize areas where CMR is not going to be as robust as echo. And I think one of these areas is when you're trying to look for dynamic LVT obstruction. I'm showing you an example case here where you can see the classic kind of late peaking dagger-shaped continuous wave Doppler signal. You'll notice because the duration of high velocity is very short, with the suboptimal temporal resolution that we have with our phase contrast CMR, we may significantly underestimate the peak velocity here. And so in general, I always say that the echocardiography is going to be much better for assessment of dynamic LVT obstruction. And then in addition to that, echo can also do Valsalva maneuvers, which are not typically able to do by CMR. So what is it that CMR is able to offer in HOCM? I think one is to identify the ventricular morphology and function in these patients, to identify the scar substrate in these patients, which is associated with increased arrhythmic risk, as well as increased heart failure death from end-stage HOCM, and then really to predict all-cause as well as cardiac mortality. And I think there's been really over the last 10 or 15 years a significant amount of data that's emerged, and this has really led to an update in the guidelines, such that in the just published ACC/AHA guidelines for hypertrophic cardiomyopathy, there's a class 1 indication now for CMR in patients where obviously there's a suboptimal or inconclusive echo, but also in patients where there's a suspicion for an alternate diagnosis, such as an infiltrative or storage disorder, as well as athlete's heart. And we'll touch on some of these other disorders later on in today's talk and next week. There's also now a class 1 indication to incorporate CMR in HOCM patients who are not otherwise identified to be high risk, to really use information provided by CMR as far as maximal wall thickness, ejection fraction, apical aneurysm, and then importantly, the extent of fibrosis to identify sudden cardiac death risk and potentially ICD candidacy. And then in addition to that, I think this is also a new criteria or new set of guidelines, which again is class 2B, which says, remember, it's important that this can be a progressive disease process. And so therefore, there is a role for repeat imaging in these patients every 3 to 5 years to assess for progression of morphologic changes, development of aneurysm, as well as progression of fibrosis. So let's move on to another genetic cardiomyopathy, which is arrhythmogenic RV dysplasia or RV cardiomyopathy. And again, notice, I always tell my fellows, imaging does not make the diagnosis of ARVC. It can provide you with some of the major or minor criteria, but recognize to make a diagnosis, you need to have 2 major criteria or 1 major plus 3 minor criteria or multiple minor criteria. So the imaging criteria by CMR are going to be 1, the presence of regional akinesis, dyskinesis, or dysynchronous contraction. So really, you have to start with abnormality in wall motion, and then you couple that to either manifestation of RV dysfunction, RVEF of less than 40, or RV dilatation. And the quantitative criteria here that are used are RV end diastolic volume of greater than 110 milliliters per meter square for men, or greater than 100 milliliters per meter square for women. So if you have wall motion and you have one of these criteria of dilatation or dysfunction, that gives you 1 major criteria for RV dysplasia. And then the minor criteria would be basically if there is lesser degrees of RV dysfunction or lesser degrees of RV dilatation. Now, another important thing to keep in mind as we're learning is that although we think of RV dysplasia as affecting the right ventricle, this pathophysiology, this condition can also have variants that affect predominantly the left ventricle. And this is something I think we're still learning much more about, but there are these left-dominant arrhythmogenic cardiomyopathy phenotypes. And there's some interesting scar pattern in these individuals where there's almost a kind of a global circumferential pattern of a ring-like hyperenhancement. And I think, again, this is something that much more work needs to be done in for us to get a better understanding of this. Let me move on to another condition, which is left ventricular noncompaction. And if we look at the cine short axis and long axis views, we can see that there's excessive trabeculation that are present here. But more important than that, I think, is when we quantify the amount of the trabeculations, and we can do something what's called the Peterson criteria, which is to compare the ratio of the non-compacted to the compacted myocardium. This is done now in diastole, that in this example patient where we have both LV dilatation, LV dysfunction, and a ratio of greater than 2.8, this is very suggestive of LV non-compaction. And in fact, in this particular study by Peterson and colleagues, they found that using a threshold of 2.3 to 1 seemed to provide reasonably good sensitivity and specificity for identifying LV non-compaction. Now, one of the things, though, that there are some issues is that this phenotype can also occur even in normal patients or in athletes as well. Another criteria that's been proposed, which seems to be a little bit more specific for LV non-compaction, is what's called the Jacquier criteria, where you're looking at the global volume of trabeculated to non-trabeculated myocardium. And if the trabeculated volume of LV mass is more than 20% of the total LV myocardial mass, then that seems to be suggestive of LV non-compaction. And there's several other criteria as well. I think by virtue of the fact that there's multiple criteria tells you that this is not a straightforward diagnosis to make always. And I'll come back to this in a second, but I also want to point out that with LV non-compaction, in addition to these hypertrabeculations and LV dysfunction and heart failure that these patients can get, they can also be at increased risk for developing a thrombus within the left ventricle. And here, using our thrombus imaging technique, we can see an area of absent contrast uptake, indicating an LV thrombus within these deep recesses. And obviously, these patients, may warrant anticoagulation as prophylaxis for LV thrombus formation. This was a very nice review article in JACC, which I think kind of highlighted the fact there's still a lot of uncertainty with regard to LV non-compaction. I think it's important to keep in mind that there's individual variability, that sometimes you can get the phenotype of hypertrabeculation in athletes in pregnancy, as well as a variety of other conditions, but that there are at least some emerging data showing an association with chromosomal abnormalities, congenital heart disease, and cardiomyopathies as well. Important, though, to keep in mind that from this recent publication by Stefan Peterson and his group, that from a prognosis standpoint, the amount of trabeculations doesn't seem to be the driver of prognosis. Rather, in this large analysis that they looked at, what they found was it was LV ejection fraction that was a predominant driver of prognosis in these patients, not the extent of trabeculations. So let's move next to the dilated cardiomyopathies. And we'll start off with this case here. And again, I think all of us would look at these CT images right off the bat and say, yes, clearly we're dealing with a case of a large apical wall motion abnormality, which obviously in the absence of angiographic evidence of flow-limiting coronary obstruction, in the presence of new EKG changes, and in the absence of other mimicking conditions such as intracranial bleed or hypertrophic cardiomyopathy or myocarditis, this would fit the criteria, the Mayo Clinic criteria for Takotsubo's cardiomyopathy. Important, though, to keep in mind, I think, as this multi-center CMR study showed, is that there can be different phenotype or phenotypic presentations of Takotsubo's. So although we think of the classical apical ballooning, which is what they found in this series in over 80% of patients, there were about 18% or 17% of patients who had this mid-ventricular ballooning pattern, as is shown here, where the basal and apical segments are spared. And then there can be a small percentage of patients who actually have a basal or inverted ballooning syndrome, where in fact there is normal wall motion of the apical and mid segments, but it's the basal segments that manifest contractile abnormality. And then also in this series, they found that nearly 1 in 4 patients exhibited RV involvement as well, and they coined the phrase biventricular ballooning. Now, as the pathophysiology here is such that there's not much in the way of myocyte necrosis or myocardial damage, the LGE also supports that in the sense that there's no evidence of significant left or of hyperenhancement in these patients with Takotsubo's. And then I think the favorable prognosis in these patients was further demonstrated in this study by the fact that on follow-up imaging, most of these patients actually were able to manifest recovery of LV ejection fraction and reverse remodeling with a reduction in their LV end diastolic volume. Here's another case. This is a 44-year-old gentleman who comes into the hospital on a Friday evening. He has a history of tobacco abuse and a family history for premature CAD. His EKG shows some nonspecific SDT changes, but he has a significant elevation in his cardiac enzymes over the weekend as he's been treated with heparin and antiplatelet agents. On Monday, when you take him to the cath lab, he has normal coronaries. And let me see. I'm not sure how well this projects on the video stream, but basically you can see his LAD system, his CIRC system, and his RCA system have no significant obstructive lesions. And so I think the question this brings up is we have a case here of a patient who has a myocardial infarction with no obstructive coronary arteries. And what's the underlying etiology of this? And there's a broad-based differential that we're left with at this point. I think MRI can actually help you to further narrow this down. So this person came for an MRI the next day after the cath, and you'll notice when we look at the post-contrast imaging, there's multiple patchy foci of hyperenhancement that we can see here, the lateral wall. If you look at the two-chamber view, you also see some foci here in the apical anterior wall as well. And on the short axis views, you can see a pretty broad patchy pattern of enhancement. This is a pattern, obviously, that's consistent with myocarditis. And there's some nice data out from Germany almost 15 years ago now, where they looked at a series of patients that presented with clinically suspected myocarditis. And what they found was, these patterns of enhancement on contrast-enhanced CMR, which obviously wouldn't fit with coronary artery. In this case, you can see an epicardial pattern. And when they biopsied in the left ventricle at the site of the hyperenhancement, in the vast majority of these patients, they found evidence of virus, either pyro or herpes type 6 virus in this series here, with only 10% of the cases having a negative biopsy. Now, furthermore, they actually went through and looked at the location of the myocardial damage and the underlying type of virus. And what they noted was that parvovirus tended to affect more the lateral wall, whereas the herpes type 6 virus tended to have more of an impact on the septal walls. And then obviously some patients where they found both virus had involvement of both the septal and the lateral wall. And I think most important was that not only was this useful in making the diagnosis of myocarditis, but it gave you prognostic implications as well. So in these patients that presented with suspected myocarditis, if there was no LGE evident, their prognosis was very good during follow-up. But if there was evidence of LGE, they had a much higher likelihood of all-cause death, cardiac death, as well as sudden cardiac death during follow-up. I'm going to wrap up here with just the last couple. And so idiopathic cardiomyopathy is kind of this cardiomyopathy where we don't have any other underlying culprit. There's a nice single center study that came out of the UK several years ago, which identified that a certain percentage of these patients can actually have evidence of fibrosis despite having an idiopathic non-ischemic cardiomyopathy. It tended to affect the septal area of the left ventricle, and it was associated with the worst prognosis. These patients had a higher likelihood of all-cause mortality, of cardiovascular mortality or need for transplantation, and also a higher likelihood of sudden cardiac death. Now, more recently, this in fact was just came out on print over the weekend in Circulation. We have now published a large multi-center series with about 1,000 patients, and the objectives for this series were to, one, look at the prognostic impact of SCAR, but also look at the impact of SCAR and LV ejection fraction on the modes of death. And what we found was when you look at all-cause mortality or cardiac mortality, then ejection fraction as well as SCAR presence or absence each provided further incremental risk. But interestingly, if we focused on sudden cardiac death or arrhythmic endpoints, LV ejection fraction, whether it was above or below 35, really didn't have much of a discriminatory capacity, but it was really the presence or absence of SCAR that identified increased risk. And this right-hand figure, I think, shows very nicely, whether the EF was more than 35 or less than 35, if there was SCAR present, there was a higher likelihood of arrhythmic composite event versus patients without SCAR, again, irrespective of whether the EF was more or less than 35%. And then, it also, when we did a cubic spline analysis, we also noted that there is a progressive increase in sudden death risk and arrhythmic composite risk with increasing SCAR extent. And again, this relationship held true whether the EF was less than 35 or the EF was more than 35. And also that it seems that about 20 to 25% SCAR burden is when the arrhythmic composite events and sudden death risk seem to plateau. So that seems to be kind of a threshold at which, below that threshold, every incremental increase in scar burden was associated with incremental increase in arrhythmic risk. And actually, interestingly, it's around the same time, just a week ago, this other publication came out as well, which was a small pilot study, which was really trying to look to see if does scar progress over time, and what happens to LV ejection fraction in this small pilot series. And what we notice is that with LV ejection fraction, there can be some patients who have an increase in ejection fraction on follow-up imaging, which was done a median of about 1.5 years later. But there's some patients who can actually have an improvement in ejection fraction. So EF is more dynamic. It can improve or get worse. Interestingly, scar never went away. So those patients who had fibrosis on the initial scan, none of them had regression or resolution of their fibrosis. And some of them, in fact, went on to have further progression. And that might explain the findings of the other study, which is that whereas LV ejection fraction is load dependent, is variable based on optimal guideline-directed medical therapy, where some patients can improve their ejection fraction, fibrosis is a much more stable and consequential substrate. And as a result, maybe this will be a better measure for making determination with regard to placement of ICD. I think more work still needs to be done. In fact, there is a randomized trial underway out of Australia trying to look at this. So I think this is an area where hopefully we'll see more and more down the road. So I think what I touched on today was the genetic and the dilated. We'll come back to next week the inflammatory and the infiltrative restrictive cardiomyopathies, as well as talk about the role for cardiovascular PET in these conditions. And so really, I think what I hope I showed you was that CMR, really with this ability to assess myocardial fibrosis, is able to aid in diagnosis, in prognosis, and I think as we'll see in the future, also provides with therapeutic management options for our patients with cardiomyopathy. So I thank you for your attention, and I'd like to open it up if there's any questions from any of the folks at Houston Methodist that are on the Zoom platform.
Am I on? Thank you, Dipan.
Yes.
That was great. So you all know you can text DeBakey to 37607 and send us any questions. We have a couple of minutes that we could do that. Dipan, while we're waiting, one interesting observation is that people who have scarring in the myocardium due to chronic pressure overload lesions like aortic stenosis, hypertension, even ACM, it has been shown that when you relieve the pressure overload, you can reverse that fibrosis. Yet what you're finding here in the non-ischemic cardiomyopathy is more of a stable pattern that doesn't change. That's kind of an interesting observation.
Well, yeah. So I think that's a very interesting thing you bring up, kind of a broad-based term. But really, I think of it, there's two different forms. There's the replacement fibrosis where there's destruction of myocytes, and it's replaced with collagen scar. And there's the interstitial fibrosis where there's not complete destruction of myocytes, but rather there's scar or collagen deposition in between myocytes. And so it's the second form, the interstitial fibrosis, that's reversible. But the replacement fibrosis that we see by LGE does not seem to be reversible.
Yeah, and that's a great point, because most of the studies that have suggested regression have been done with biopsy, and they have really seen more of the collagen deposition interstitial, which is, it's not replacement fibrosis, more of the other one. All right, so let's see. We haven't seen any questions, so at this time the hour has passed, and thank you very much for being viewers in this conference, and we invite you to continue to come every Tuesday at noon for our completion of our imaging series in our academic year. Next time, as Dipan said, will be the continuation of this topic, looking at how CMR and PET help us manage these patients. Thank you.
Thank you.